Welcome back to the deep dive. This is where we really break down complex topics so you can achieve mastery. Today we're tackling something absolutely critical in modern healthcare: outpatient anesthesia and ambulatory surgery. If you want to understand that intersection of efficiency and safety, well, this is ground zero.
It really is. We're talking about a fundamental shift, how surgical care is delivered. It's not like the old days where almost everything meant days in the hospital. Now, the whole idea is patient comes in, has the procedure, and is safely home, usually well before that 24-hour admission clock ticks over.
Right. And terminology can be a bit tricky here. You hear outpatient, ambulatory, sometimes 23-hour observation.
That's a really important point right away. Those terms outpatient, ASC, 23-hour obs, they often get used almost interchangeably. Even that 23-hour observation patient, maybe they stay overnight, but if they're discharged safely before 24 hours, they still fall under this big outpatient umbrella.
And the numbers, the sheer scale of this change, it's pretty mind-blowing. Back in, 2006, around 35 million procedures?
Just the starting point, yeah. And then boom. By 2018, we're looking at 129 million. The projections were heading towards 144 million by 2023. This isn't just a little trend, it's a complete reshaping of surgery. So our goal today, our mission for you, is to go beyond just knowing this is happening. It's about getting that deep understanding, mastering the complex decisions, the strategies, the stuff the real pros use in this very busy, high-stakes world.
Exactly. So if you want to truly master the nuances, patient selection, anesthetic approaches, the things the top people in this field live and breathe, then this deep dive is definitely for you. Okay, let's peel back the layers. Where did this all start? I mean, ambulatory surgery feels modern, but it actually has some pretty deep roots, doesn't it?
Oh, absolutely. Way deeper than you might think. The very first ideas were for really small things. Think dental offices using nitrous oxide, simple, convenient. Then doctors' offices started doing minor surface procedures, mostly just with local anesthetic.
But the first real proof, documented proof, goes back more than 100 years.
Yeah.
That Neckel report in 1909.
Yes, Nicole's work is foundational, really. He reported on, get this, 8,988 outpatient procedures at the Glasgow Royal Hospital for Sick Children. It showed it was possible, and importantly, safe enough, especially for minor things in kids. This wasn't just theory, it was real-world practice, and a lot of it.
And then just a few years later, 1916, Dr. Waters took it a step further, outside the hospital walls entirely.
That's the key move. Dr. Waters opened the first proper freestanding unit just for outpatient surgery, Sioux City, Iowa. That was really the model for the modern ASC, showing you could have dedicated places outside the hospital doing this safely.
So the seeds were planted early. But the explosion we see now, this huge industry, that needed more recent fuel, right?
Totally. It's like a perfect storm, really. 4 big things came together over the last few decades. 1, surgical innovation. Think minimally invasive, laparoscopy, all that. 2, new anesthetics. Those fast-on, fast-off drugs that make quick turnover possible. Huge deal. 3, patients and doctors actually prefer it. People want to recover at home. And 4, the big one, insurance companies pushing hard for cost control. That's a massive driver.
And the range of surgeries done outpatient now,
Yeah.
it's incredibly broad.
It's vast. Dental, ortho, GI, eyes, ENT, GYN, cosmetic, even some cardiac and urology. But here's the really interesting part, and where you need real mastery. We're now doing tougher procedures on patients who have complex health issues, routinely outpatient, which means the anesthesia provider absolutely must ensure those underlying conditions are perfectly managed, optimized through the whole process.
Okay, and this brings up the difference between a typical ASC and this growing thing called office-based surgery, or OBS.
Right, OBS. It's a significant chunk now, maybe 15%, 20% of all surgeries. The draw is obvious. It's super efficient and generally costs less than hospitals or even ASCs. Technically, the anesthesia and surgery aren't all that different from what you do in an ASC.
But doing surgery in an office,
Yeah.
that sounds like it needs extra scrutiny, right? Fewer built-in safety nets.
Absolutely. It can be done safely, but you don't have the immediate backup resources. That definitely raises the stakes. That's why the standards are so crucial. Groups like the ANA, the ASA, the Joint Commission, they have really strict guidelines for office-based practice. It's all about picking the right patients and being ready for emergencies.
All right, let's shift gears. Why this huge move? What are the real benefits driving it? There seem to be financial, medical, and even social reasons. Let's start with the money.
Well, the financial side is layered. It benefits everyone, really. Patients, payers, the facilities themselves. For patients, it's lower bills, less time off work for them, or a caregiver, less need for childcare. Those indirect costs add up. For the insurance companies, the payers, Cost containment is probably the #1 reason this whole system has shifted so dramatically.
And we're talking real money, not just pocket change. The savings estimates were huge, right?
Oh,
Yeah.
yeah. Projections were hitting like $4.2 billion up to maybe $9.4 billion saved annually by 2022. That's a massive leap from just $2.3 billion back in 2011.
How do they save so much? Is it just efficiency?
That's the core of it. Ambulatory centers are like specialized factories. They're designed for specific types of procedures. They pick relatively healthy patients, so they can just run cases much, much more efficiently than a big, complex hospital OR that has to handle everything. Higher volume, faster turnover.
Okay, finances aside, what about the medical pluses? Especially for the bigger picture, the whole healthcare system.
That's a really critical point. Medically speaking, doing more outpatient surgery frees up hospital beds. Those beds are precious resources needed for the really sick patients who have to be admitted. And maybe even more important, especially for vulnerable people, kids, older folks, people with weak immune systems, cancer patients, transplant recipients. Keeping them out of the general hospital environment drastically cuts their risk of picking up nasty hospital-acquired infections. Nosocomial infections, that's huge.
And patients themselves seem happier with it.
Overwhelmingly, yes. Patient satisfaction scores are consistently higher. Some of it's practical shorter waits, lower costs, easier scheduling. But honestly, a big part is psychological. Recovering in your own bed, your familiar surroundings, that's just way better than a hospital room for most people.
And that comfort factor plays out differently for kids versus older adults.
It really does. For kids, less time separated from parents is a huge stress reducer. Less disruption to feeding, routines. Having mom or dad there helps enormously, especially if the child has other challenges, mental or physical impairments.
And for older patients, the geriatric group, you mentioned something about cognitive benefits.
Yeah, it's fascinating research. Older patients seem to do better cognitively and physically when they're not pulled away from home and family for long. They stick to their routines, better diet, meds, sleep. Plus, there's good evidence suggesting less postoperative cognitive dysfunction, that post-op fogginess, because they often get less sedation overall and get back home quicker compared to inpatients.
Okay, lots of upsides, but it can't all be perfect. What are the downsides, the trade-offs we need to acknowledge?
Right, the reality check. That efficiency comes at a cost. You have less time for observation, less time to catch subtle problems early on. Privacy can sometimes be less, depending on the setup. And the patient has to be more proactive, maybe multiple trips for screening beforehand, and them being really diligent with home care instructions afterwards. Compliance can be an issue.
And the biggest issue, the fundamental limitation, especially for those freestanding or office centers.
Is the lack of immediate backup. That's the absolute bottom line. If something goes seriously wrong, a major bleed, a bad reaction, a medical emergency, those places just don't have the resources on hand. No blood bank next door, no ICU team down the hall. You have to transfer them to a full hospital, and that transfer takes time, introduces risk. That limitation is precisely why patient selection has to be absolutely meticulous. You can't afford major surprises.
Okay, so that lack of immediate backup makes the pre-op assessment absolutely critical. This gets us to the real core skill, mastering patient selection. I mean, thankfully, the rate of unexpected admission is super low, right? Less than 0.08%. But figuring out who falls into that tiny percentage, that's the challenge.
It's exactly the game. We look for known predictors. Things like age, how frail the patient is overall, their ASA status, the specific type of surgery, and known complications like bad nausea and vomiting, pain control issues, fluid shifts, bleeding risk. The basic rule of thumb. The patient's underlying health issues need to have been stable for at least 3 months beforehand.
Let's start with the group that probably needs the most careful thought. Kids. The pediatric challenge.
Right. Infants under 2 just generally have a slightly higher admission rate, but the real high-risk group, the ones you have to be incredibly cautious with, are former premature infants born before 37 weeks gestation. Generally speaking, the conservative view is they're just not appropriate candidates for outpatient surgery. Why? Because of specific physiological issues they have.
Can you walk us through those red flags? What makes them so risky for ambulatory care?
Sure. There are 4 main things. First, anemia. Their hemoglobin can drop quite low, maybe 7 or 8 in the first few months after birth. That makes them much more prone to apnea after surgery. Second, their gag reflexes might not be fully developed, higher aspiration risk. Third, immature temperature control. They get cold easily, and hypothermia itself can trigger apnea. And fourth, and this is key, their brainstem function is still developing. That part of the brain controls breathing, and its immaturity makes them prone to stopping breathing apnea.
Apnea. That seems to be the central danger. How do we define it in these tiny patients?
Yeah, apnea is the big one. We classify it. Short apnea is a pause of 6 to 15 seconds. Prolonged apnea is over 15 seconds. And then there's periodic breathing, basically. Multiple shorter pauses close together. The scary part is this post-op apnea can happen up to 12 hours after the surgery.
Wow. So given that unpredictable risk, what's the safe, standard age cutoff for former preemies?
The standard conservative approach is pretty strict. If a healthy former preemie is less than 60 weeks post-gestational age, that's their age at birth plus their current age, they need to be admitted for monitoring, period. You just can't reliably predict who will have apnea, so you need that safety net of extended observation in the hospital.
What about babies born full term?
Full-term babies, if they're otherwise healthy, can be considered for minor procedures outpatient. There aren't rigid guidelines from the big societies yet, but a lot of places use a cutoff around 50 to 52 weeks post-conceptual age. And they'll often require a longer observation period, maybe 4 hours in phase 2 recovery.
And we also have to think about SI risk factors, right?
Absolutely. Any infant with a history of apnea spells, or tragically, a sibling who died from SIDS, they're considered high risk. The peak SIDs risk is between 1 month and 1 year. So for these high-risk infants, you really shouldn't consider elective outpatient surgery until they're at least 6 months, maybe even a year old.
You mentioned ways to minimize apnea risk. Anesthesia techniques.
Yes, regional anesthesia seems to be much better here. Using something like a spinal block, especially without heavy sedation added on, that's been shown to lead to much less prolonged apnea, fewer oxygen desaturations, less slow heart rate compared to general anesthesia, or even a spinal with ketamine sedation.
Okay, let's jump to the other end of the age spectrum, the geriatric population.
Yeah.
65 and older.
Right. For older adults, it's less about the number, their chronological age, and more about their physiologic age, their overall health and reserve. The main issue is usually multiple other health problems that come with age. All of those need to be well controlled, optimized before surgery. That said, being over 80 is a strong predictor on its own for needing admission after outpatient surgery. And crucially, for older patients, you absolutely have to nail down the post-discharge plan beforehand, reliable transport, a capable caregiver at home.
Okay, moving into specific conditions that demand really expert preparation. Malignant hyperthermia, MH.
MH, yeah. Rare, but potentially lethal. We screen carefully. A patient is considered susceptible if they've had it before, had really rigid jaw muscles under anesthesia before, or if a close relative, first degree, had an MH episode, or if they have certain muscle diseases like central core myopathy.
And if you know someone is MH susceptible and you give them a safe, trigger-free anesthetic, the facility itself has to be ready, right?
Non-negotiable readiness. The facility needs a fully stocked MH cart, proper monitoring, full resuscitation gear, and critically, at least 36 vials of dantrolene sodium, or the newer form, Ryanodex. That huge number reflects how much drug you might need in a full-blown crisis.
What about discharge for that susceptible patient after an uneventful trigger-free case?
They don't automatically need to stay overnight just because they're susceptible, but you must schedule them early in the day. Allows for longer observation and recovery. You need to be absolutely sure there are 0 early signs of MH, no subtle rise in CO2 or temperature before they can even be considered for discharge.
And if there are subtle signs, even mild ones?
Any marked jaw muscle rigidity, any temperature increase, any sign of muscle breakdown in the urine, myoglobinuria, or rising CK levels, that means mandatory overnight observation in a monitored setting. Even just mild jaw tightness means watching them for at least 12 hours. And if you see that cola-colored urine, that's myoglobinuria, a sign of major muscle breakdown, that's an emergency transfer to a full hospital immediately for advanced care because their kidneys could fail.
Next up, morbid obesity. Class 3. Used to be a definite no-go, but that's changing.
It is evolving, yeah. BMI between 35-40 used to be pretty much an exclusion due to high risk of breathing problems after surgery, but that's being looked at again. We're even seeing some procedures, like lap bands, done outpatient now in carefully selected patients.
Still need caution, though, especially at the really high end of the BMI scale.
Oh, absolutely. BMI over 50. Extreme caution, especially if they have other serious issues, heart, lung, kidney disease. The airway evaluation before surgery is absolutely vital for these patients. Careful Mallampati check, neck size, jaw movement. Predicting a difficult airway is key to preventing disaster.
And obesity often goes hand in hand with obstructive sleep apnea, OSA. That's a huge risk for outpatient failure.
A massive risk. Screening is essential. We use tools like the Stop-A-Bang questionnaire, snoring, tiredness, observed apnea, pressure, high blood, BMI, age, neck size, gender, score over 3, high suspicion. The danger is anesthesia makes everything relax, including the throat muscles, leading to airway collapse and dangerous drops in oxygen after surgery.
So what's the main strategy for the anesthesia provider to manage that known risk?
It boils down to anesthetic choice. Minimize or completely avoid benzodiazepines and opioids during the surgery. Opioids knock out their drive to breathe and make it harder for them to wake up if their airway blocks. Pain after surgery needs to be managed mostly with non-opioids or good regional blocks. And if they use a CPAP machine at home, they must bring it to use immediately after surgery.
And the discharge criteria for OSA patients have to be really strict.
Crystal clear guidelines from the Society for Ambulatory Anesthesia. If they have a known diagnosis and their other health issues are optimized, they can be candidates if they can use their CPAP after discharge, and pain is manageable without heavy opioids. If OSA is just suspected, not diagnosed. Only if comorbidities are optimized and pain control uses non-opioids or regional. If they need lots of IV opioids post-op, they're likely not safe to go home. Plus, all OSA patients need an extra 3 hours of observation before discharge, specifically watching for periods where they breathe normally on their own.
Okay, last specific condition. Sickle cell disease, SCD.
SCD needs extreme care. The problem is red blood cells changing shape, sickling, which gets much worse with low oxygen, dehydration, getting cold, or acidosis. So management is all about keeping them warm, super well hydrated, and making sure their oxygen levels stay normal. To even consider outpatient surgery, the patient needs to meet strict criteria. No major organ damage from the SCD, no sickle crisis in the last year, proof they follow medical advice, and guaranteed quick access to medical care after discharge. Plus, the surgery needs to be short, scheduled early in the day for prehydration and extra monitoring time.
Okay, let's pull this section together. What are the absolute deal breakers? Conditions that mean ambulatory surgery is just off the table.
The hard stops are unstable ASA, 3 or 4 patients think uncontrolled diabetes, unstable angina, severe heart disease, active drug or alcohol abuse, no responsible person to care for them afterwards. Also, uncontrolled seizures, poorly managed moderate to severe OSA, and those ex-premature infants under 60 weeks post-conceptual age needing general anesthesia. And critically, if you anticipate severe pain that you know will be hard to manage after discharge.
All right, so the pre-op evaluation is obviously essential. But the way we do it, the philosophy has changed a lot, hasn't it? Driven by efficiency.
Huge paradigm shift. The assessment now has to be driven by what you find in the patient's history and physical exam. We've gotten away from that old, inefficient, costly approach of ordering a standard battery of tests on everybody. Why? Because study after study shows routine screening labs on healthy people rarely predict problems and almost never change how we manage the patient. We're talking less than 0.5% of the time. It's just not good value.
So tests only if something in the clinical picture points to a potential problem.
Yeah.
What about the timing? When should this evaluation happen?
For your higher-risk patients, complex cases, multiple health issues, get it done at least a week before surgery. Gives you time to optimize things. For generally healthy folks, you can do the evaluation on the day of surgery for convenience. But that comes with a higher risk of canceling the surgery last minute if you uncover something unexpected, like they didn't fast properly, or you suddenly suspect a difficult airway, or find an unknown serious illness.
And if labs were done previously, how long are they considered good for?
If the lab results were normal, they're generally considered okay for up to 6 months before surgery, provided, and this is crucial, the patient's health hasn't changed significantly in that time. But there are key exceptions for things that change quickly. Potassium levels, especially if they're on diuretics or digoxin, need to be checked within 7 days. And blood sugar, for all diabetics, needs to be checked the morning of surgery. No exceptions there.
Okay, let's talk fasting. This is huge for aspiration risk. We've moved way beyond NPO after midnight, haven't we?
Oh, thank goodness, yes. That old rule was a blunt instrument, didn't account for surgery times, caused dehydration, low blood sugar, made patients miserable, and probably didn't even improve safety much. We know aspiration risk is higher in certain people, very young or old, anxious patients, those with hiatal hernias, severe obesity, pregnancy, or significant pain.
So what are the current evidence-based rules? How long do healthy patients really need to fast?
The guidelines are much more liberal now and much better for patients. Clear liquids water, juice without pulp, black coffee, clear tea are okay up to 2 hours before surgery. Good evidence shows this doesn't increase risk. Breast milk needs 4 hours. Infant formula or a light, non-fatty meal needs 6 hours. It balances safety with keeping patients hydrated and more comfortable.
What about their regular medications? Take them or hold them on surgery morning?
General rule: Take your prescribed meds as usual, right up until surgery morning. Just use a tiny sip of water, maybe up to 150 milliliters for adults, up to about an hour before anesthesia starts.
But there are important exceptions, meds that often do need to be held or adjusted.
Yes, key ones to watch are aspirin and other antiplatelet drugs that depends heavily on the surgery and cardiologist input. Diuretics are usually held to avoid dehydration. And certain blood pressure meds, specifically ACE inhibitors and ARBs, are often held because they can cause really stubborn low blood pressure under anesthesia.
And managing warfarin, Coumadin, that needs careful planning.
Absolutely high stakes. If the plan is to stop it, that's usually done about 5 days before surgery. Often needs bridging with shorter-acting anticoagulants like Levinox or heparin to prevent clots during that time. You must check the INR level on the day of surgery to make sure it's safe to proceed. Then, if bleeding is controlled, warfarin is typically restarted 12 to 24 hours after surgery.
Diabetic patients need careful planning, ideally scheduled early in the day.
Early scheduling is key to minimize fasting time. The assessment has to look at their overall sugar control. Check the HbA1c. If it's high, maybe over 6.9, you might need an endocrine consult. The goal during surgery is a balancing act. Prevent dangerous low blood sugar, but also keep the sugar level reasonably controlled, usually under 180.
How do you manage their insulin doses that morning to hit that target?
Depends on the type. Long-acting basal insulins, like Lantus or Levemir, usually take a reduced dose, maybe 15–20% less than usual, the morning of surgery to avoid lows. But the short-acting or rapid-acting insulins they take with meals, those are typically held completely that morning. Oral diabetes meds and other injectables might also need to be held that requires specific instructions from their doctor.
Lastly, the common headache. The patient shows up with a runny nose, upper respiratory infections, URTIs. When does that mean? Postponing.
Yeah, URTIs cause a lot of cancellations. You have to figure out if it's just allergies, seasonal stuff, which usually isn't a reason to cancel, or a genuine infection. Giving anesthesia to someone with an active infectious URTI significantly bumps up the risk of breathing complications, laryngospasm, bronchospasm, croup after the tube comes out by like 2 to 7 times.
So what's the decision process? When do you absolutely have to delay and for how long?
It hinges on systemic symptoms and whether the lower airways are involved. General rule: delay surgery 4 to 6 weeks if they have signs of a lower respiratory infection, like a wet chesty cough. Systemic symptoms: fever over 38.5 C, feeling generally unwell, or if the surgery requires putting in a breathing tube. However, if they have no fever, secretions are clear, and you can manage the airway with just a mask or an LMA. You might cautiously proceed after carefully weighing the risks and benefits.
Okay, patient's ready, evaluated, prepped. Now, the anesthesia itself, what are the specific goals guiding anesthetic choices in the outpatient world? Speed and safety seem paramount.
Absolutely. Everything is geared towards fast turnover and minimal hangover effects. You want to minimize how much you disrupt their normal physiology. You need a fast, smooth start, and just as importantly, a fast, smooth wake-up. Good amnesia, good pain control, obviously. And critically, minimizing side effects like nausea, vomiting, dizziness, those things delay discharge.
For general anesthesia, that means leaning heavily on drugs with quick on, quick off profiles.
Exactly. We rely on the less soluble inhalational agents, the gases like dyslorane and sevoflurane. Low solubility means they get into the brain fast and leave the body fast when you turn them off. Quick wake-ups. Combine those with short-acting IV drugs like propofol for induction and short-acting muscle relaxants if needed. Everything geared for rapid recovery.
And airway management. Seems like LMAs, those supraglottic airways, are often preferred over breathing tubes when possible.
Definitely. LMAs are workhorses in the ambulatory setting. Patients tolerate them with less deep anesthesia compared to an endotracheal tube. That often means less need for muscle relaxants too, the payoff. Less sore throat, less coughing afterwards, which means a smoother recovery and often faster discharge readiness.
What about monitoring brain activity with BIS, bispectral index? Does that actually help speed things up in an ASC?
The data's a bit mixed on using it routinely for everyone, but in the outpatient setting, there are recognized benefits. BIS can help you fine-tune the anesthetic dose, potentially use less gas overall. That can contribute to faster wake-ups. And there's some evidence it might even help reduce nausea and vomiting during the later recovery phase.
Let's talk fluids and this concept of ERAs, enhanced recovery after surgery protocols.
Right. ERAS is all about optimizing the patient journey, reducing surgical stress, shortening stays, improving recovery overall. For fluids, the ARAS approach isn't about flooding patients, but giving fluids when indicated. Like for procedures over 30 minutes, cases with high P1V risk, if someone's been fasting a really long time, especially kids over 15 hours, or if there's expected bleeding. Keeping patients adequately hydrated is important. Dehydration definitely contributes to nausea and just feeling lousy afterwards.
Regional anesthesia seems like a real game changer for tackling the big two discharge delays: pain and nausea.
It's probably the single best tool we have for that. Good regional blocks demonstrably improve pain scores. That means way less need for IV opioids, which directly translates to less nausea and vomiting, and ultimately shorter stays in the recovery room. Simple local infiltration by the surgeon is great for small cases, but these advanced peripheral nerve blocks, PNBs, especially done with ultrasound guidance now, they're incredibly effective for arm and leg surgery. Can give fantastic pain relief for up to 24 hours sometimes, makes that recovery at home much smoother, fewer bounce backs.
Given how well they work inpatient, why aren't spinal or epidural blocks used more often for outpatient cases?
They work, but the challenge is they can delay recovery too long for the fast pace of an ASC. If you do use them, you absolutely have to pick the shortest acting drugs possible, things like lidocaine or prilocaine. We know even a small dose of a longer acting drug like bupivacaine can significantly push back discharge readiness, sometimes by hours. And adding epinephrine to spinal anesthetics, generally avoided because it really increases the risk of urinary retention, which is another major cause of discharge delay.
Okay, let's dive into the drugs used specifically to prevent aspiration in high-risk patients. What are the main types and how do they work?
Right. For those at higher risk, severe reflux, obesity, diabetes, etc., we have a few pharmacological tools. Three main classes. First, antacids, like sodium citrate, Bicitra. These work instantly by neutralizing existing stomach acid. Give them 15-20 minutes before induction. We prefer the clear, non-particulate ones. Downside, they raise pH but slightly increase stomach volume. Second, gastrokinetics, like metoclopramide, Reglan. These help empty the stomach faster and tighten the valve between the esophagus and stomach. Need to give them about 20-30 minutes before induction if IV, maybe 45 if IM. Third, H2 receptor antagonists like famotidine, Pepcid. These block the stomach from producing acid in the first place. Best given the night before and down a warning of surgery. Famotidine is often preferred now, longer acting, fewer side effects than older ones like cimetidine. And fourth, you could add proton pump inhibitors, PPIs, like omeprazole. These are very potent acid blockers with long duration. IV omeprazole given even after induction can be effective.
Okay, we're nearing the finish line: recovery and getting the patient safely home. Despite all the advances, what two problems still most often lead to that dreaded, unplanned hospital admission?
It consistently comes down to two things: pain that's not well controlled and postoperative nausea and vomiting, PONV. Those two account for almost all unexpected admissions. Even though overall the admission rate is thankfully very low, less than 2%, certain surgeries like laparoscopic hernia repairs or bigger orthopedic cases just have a higher built-in risk because of the pain involved.
So managing pain effectively after surgery isn't just about comfort, it's about preventing admission. Needs a proactive, multi-pronged approach.
Absolutely. Multimodal analgesia is the standard of care. Start before the pain starts, maybe NSAIDs or Tylenol preoperatively. Use regional blocks whenever you can. Then in the recovery room, PACU, manage breakthrough pain carefully with small titrated doses of short-acting IV opioids like fentanyl. But the crucial step is transitioning them to oral pain meds early in recovery and making sure those pills are actually working before they walk out the door. Can't just hand them a script and hope for the best. We know uncontrolled pain is still reported quite often, maybe 12% of cases, so confirming the oral regimen works is vital.
Let's nail down the criteria for safe discharge. It needs to be objective, standardized, right, not just a gut feeling.
Exactly. You need clear, criteria-based discharge scoring systems. Makes it consistent, reproducible, takes out the guesswork. Key things you have to check off: vital signs stable and appropriate for their age, mental status clear oriented to person, place, time, breathing comfortably, no distress, minimal bleeding from the surgical site, and critically, pain controlled and nausea vomiting controlled.
Now, the voiding question. Does everyone have to pee before they can leave?
That's a common misconception. No, voiding is not mandatory for every single patient. It's only required for patients considered high risk for postoperative urinary retention. That includes people with a prior history of retention, those who had pelvic or urologic surgery, or maybe needed a urinary catheter during the case. For that group, yes, you need to confirm they can void, or maybe use a bladder scanner to make sure they aren't retaining a large volume before sending them home.
Okay, they meet all the criteria. The last crucial piece is ensuring that recovery at home, phase 3, is safe. And that hinges on the caregiver.
Completely. You absolutely must confirm before surgery that they have a responsible adult who can take them home and stay with them. Depending on the surgery and the patient, especially older folks, they might need help for 24, even 48 hours. And that caregiver needs crystal clear instructions, both written and verbal.
What are the absolute must-cover points in those discharge instructions for the caregiver?
Beyond the specifics of meds and wound care, you have to hammer home the activity restrictions. No driving, no operating machinery, absolutely no alcohol, and no making important financial or personal decisions for at least 24, maybe 48 hours. Anesthesia lingers. They also need clear 24/7 contact info and explicit instructions on when to call, like fever over 38.3 C, about 101 F, pain getting worse despite meds, persistent vomiting, and finally, manage expectations. Just because the surgery was fast doesn't mean recovery is instant. Let them know it might take several days, maybe even a week, to feel fully back to normal.
Looking back at all this, it really highlights the complexity. This field isn't about cutting corners. It's about applying incredibly rigorous, evidence-based risk assessment and meticulous planning to get optimal outcomes in a much faster time frame.
Exactly. Mastery here is defined by safety, not just speed. And as ambulatory surgery keeps expanding, the standards have to keep evolving too, especially around patient selection for those challenging groups, the tiny babies, MH susceptibles, the OSA patients. Nailing those criteria is everything. And as we get better and better, doing more complex things outpatient, it does raise a big question, doesn't it? We know regional anesthesia slashes risks and speeds discharge. So what are the next boundaries? What physiological limits may be around pain or mobilization or nausea control will we need to safely redefine to push ambulatory care even further, maybe serve even more complex patients without ever compromising that safety margin? It's something for all of us in the field to think about.